Welcome to everybody who's listening in or watching this recording. My name's Kelly. I'm one of the consultant clinical scientists at Cleveland Clinic London and also chair for membership resources with BSE. Today, we're having a discussion around pulmonary hypertension and also our last release of the pulmonary hypertension guidance. I'm joined here by three experts in this area. So first of all, someone who you'll know quite well is Professor Dan Augustine, who's a consultant cardiologist at Royal United Hospital in Bath, but also our BSE president and also lead of this pulmonary hypertension guideline. So, and a very important opinion. We've also got Dr. Abdul Hameed, who's a consultant cardiologist who has a special interest in pulmonary hypertension and is based at the National Pulmonary Hypertension Centre in Sheffield. And then we've got Dr. Heba Nashat, who is a cardiology consultant at the Royal Brompton. And Heba has an interest in pulmonary hypertension and also ACHD. So with those experts in the room, I thought we could have some really nice guided, interesting discussion around the guideline, where we are at the moment and where we might see ourselves in the next few years. So Dan, if I can start with you. Our last guideline was published in 2018, which seems like such a long time ago now. You were the lead author of that guideline. Can you tell us a little bit about the important changes that this guideline brought with it and any feedback that you received regarding its release?
Thanks, Kelly. So the main change from the pulmonary hypertension guidance in 2018 was moving away from trying to define a precise pulmonary artery systolic pressure by echo to a probability-based system where you give the probability of pH being present as low, intermediate, or high. And the rationale for doing this was that when you look at population type data and you have a pulmonary artery systolic pressure by echo, it isn't as accurate as the gold standard, which is right heart catheter. And the errors that were occurring, say with TRV max, if you have an error at baseline and you put it into the Bernoulli equation, you're squaring it and then you're quadrupling it. So if you have a small error at baseline, it can really magnify. And that's why the international guidance, and it wasn't just British guidance, the ESC guidance, the European guidance as well, went from a sort of a precision-based pulmonary artery systolic pressure to a probability-based approach. And in the intervening 7 years, what's come from that is really feedback from members in terms of how they have found this change. And the big overwhelming feedback is actually what do they then do with the report that suggests intermediate probability pH or high probability pH. Something that we'll need to work on, and we are working on, is our guidance after the report, to the person who is making the request for the echo. How do they interpret what to do with this echo report that suggests a low, intermediate, or high probability based assessment of pH? And that's things like, well, could it be due to right heart disease? Could it be due to left heart disease? Could it be due to valve disease? And then what do you do with the patient after that from an echo perspective? And a lot of things have changed since the initial guidance, and what we're fortunate enough to have now is more research on more novel techniques. And so right ventricular free wall strain, for instance, the amount of publications on that has increased significantly. And there's been the TVARC research group, so the Tricuspid Valve Academic Research Consortium, who recently looked at patients with severe TR, and it's usually just functional TR due to left heart disease, most of those patients. And what they've looked at is what is the prognosis using TAPSE, the gold standard that we've used for function for years and years. What is the prognosis with TAPSE, and can strain be additive to that? And what they found really nicely is that if you have a normal TAPSE and an impaired strain, your prognosis is worse than if you have some mildly impaired RV function parameters and a normal strain. So actually what they're suggesting is that strain falls earlier than most of the functional parameters that we know, and the prognosis is good. And so what I think will come into the guidelines is that strain is going to be more of a player.
I agree with you, Dan, and I think that's a really important point. We're definitely going to get on to what might be coming in our next iteration of the guidelines. But Abdul, if I can come to you and we focus on the consequences of our previous guidance, can you tell me a little bit about the impact of using these probabilities of pulmonary hypertension? What did it mean in terms of the echo requests that you were receiving, who was referring to you, and also what those patients looked like from an intermediate and high probability of pulmonary hypertension perspective?
Thanks, Kelly, and thanks to everybody for inviting me. I think the guidelines from the BSc from 2018 built upon the ESC guidelines from 2015, which were pretty similar in characteristics in terms of the categories. And I joined the Pulmonary Vascular Service in 2019. So I've seen a year-on-year increase in use of the probability classification in echocardiography reports. Now, we're a regional center in the north and a very large one, and that's high volume. And we see the full spectrum of patients with pulmonary hypertension and all of the groups, and often patients can be in more than one category. And we've seen increased referrals. We receive around 25 referrals a week, and people who refer the patients utilize the echocardiography report and the probability to determine the need to refer patients. And so I think it has been very helpful to increase recognition and awareness of pulmonary hypertension. And I think there are obviously areas for refinement. The reports are obviously variable in nature, and obviously allowing for imaging challenges in patients. The probability score we found has been beneficial in increasing traffic and appropriate referrals, but clearly the pretest probability for pulmonary hypertension was likely to be left heart disease and lung disease in at least 3/4 of the patients. So many patients, we have very overt left heart disease and lung disease. So I think it has been beneficial in answer to your question, and it is routinely employed now, and I'd say that it's been the case for at least 5 years. And I think naturally there's a gradual uptake in use of guidelines by echo departments, and as they become more and more accredited, so therefore they'll be utilizing that much more.
Yeah, I think that they have been very useful. It's a different way of looking at it. Heba, what's your view from an adult congenital perspective? Because you would see quite a large subset of those particular patients.
Okay. Thank you very much, Kelly, for the invite and the opportunity to talk. So certainly, I mean, with the BSc guidelines, one of the advantages is the standardized approach. The important thing when it comes to congenital heart disease mostly is actually serial imaging. The majority of these patients are in lifelong cradle to the grave type of management, and one of our echocardiographic screening is routine and regular in their follow-up. So the standardized approach does help when there is conventional anatomy, so in a post repair group. However, well, some of the post repairs, when you have all the chambers aligning as per what we deem normal, but of course we have a proportion of patients without the conventional anatomical arrangements. And in those patients, the BSc guidelines and the standard cutoffs do not apply to those patients. And so we tend to rely on some other parameters, a high index of suspicion and expert consensus in managing those particular patients. And that would include patients, say, of the Fontan circulation, pulmonary atresia, those with torrential TR due to perhaps Epstein anomalies. So it helps, and it certainly has increase the awareness truly for in screening our patients with congenital heart disease for pulmonary hypertension, for those with standard anatomical arrangements. But the congenital heart disease group are kind of familiar with screening for pulmonary hypertension, as they are an at-risk population. And also we know that some specific pulmonary patients with congenital heart disease are at higher risk of pulmonary hypertension. So there's a lot of drive from high index of suspicion and certainly the monitoring of serial data and serial changes that increase our suspicion for pulmonary hypertension in this group.
Perfect. I suspect a high level of multidisciplinary team working in for those patients as well.
Yeah, integral.
Yeah, vital. I completely agree. So one thing that we did see in 2022 was the publication of a joint ESC and also European Respiratory Society more updated guidance. In this document, they described new definitions for pulmonary hypertension. They talked about exercise pulmonary hypertension, and they also talked about new cut points for pulmonary vascular resistance. Abdul, could you talk a little bit more about that to our echo audience who may not be familiar with some of those terms?
Sure, no, that's a really important point. I mean, the pulmonary, just generally speaking, the pulmonary circulation is a low pressure, low resistance circulation, and has an almost identical cardiac output to the systemic circulation. So therefore, it operates at much lower pressure profile and can accommodate increased flow. And that's relevant in terms of exercise. But with regards to cutoffs, I mean, if we look at the historical studies, the late eminent Paul Wood from the National Hospital in London characterized normal pulmonary pressures in healthy volunteers, and it was determined that it was in the region of around 16 millimeters of mercury, plus or minus a small standard deviation. And in the 1970s, when the first World Health Organization symposium classified pulmonary hypertension, they used a somewhat arbitrary cutoff of a mean pulmonary artery pressure of 25 millimeters of mercury. And so therefore, the subsequent last 2 decades that have tested the various medications for pulmonary hypertension have used that cutoff. But what was originally apparent many decades ago and has been restudied in more recent times is what is the natural cutoff for what is defines this upper limit of normal pulmonary artery pressure. And I think we've determined that to be a mean pulmonary artery pressure of 20 millimeters of mercury. And I think it's important to qualify that this is based on right heart catheterization, and this is not the same as pulmonary artery systolic pressure, which is what we normally estimate on echocardiography. So the mean pulmonary artery pressure has been reduced from 25 millimeters of mercury to 20 millimeters of mercury, but pulmonary hypertension is heterogeneous. It can be due to increase in resistance, or it can be due to increase in flow. So, for example, shunt lesions or hyperdynamic states can have an increase pulmonary artery pressure. Doesn't necessarily mean that you've got pulmonary vascular disease. So in order to qualify pulmonary vascular disease, whereby we say there's a disease of the small arterioles and elevation of resistance, we have to determine the pulmonary vascular resistance. Now, the pulmonary vascular resistance is the flow across the pulmonary bed. So your mean pulmonary artery pressure, take away, subtract the left-sided pressure, which we normally determine from a pulmonary artery wedge pressure or an LV end diastolic pressure, all at invasive assessment, divided by the cardiac output. Now, leaving those numbers aside, the PVR was also set historically at 3 Wood units, but data has nicely determined that actually your normal pulmonary vascular resistance should be below 2 Wood units or 160 dynes, depending on which format you use. And that's been well described now. And there's a lot of epidemiological studies that have shown an association that once your mean pulmonary artery pressure goes above 20 millimeters of mercury in various populations, as well as your PVR goes above 2 Wood units, then you will see a linear increase in the risks of adverse events, including mortality, heart failure, hospitalization, etc. So MACE. So that's why we lowered the normal range to what was physiologically determined from research. So that's what's changed. Now, with regards to pH and exercise, that's been a matter which has dipped in and out of the guidelines over the last 10 to 20 years. And we've also established through research that normally when you exercise, your pulmonary artery pressure will increase. So if you went for your morning run or swim or jog, your cardiac output will increase by 2 or even 3-fold, depending on the nature of your exercise. So pulmonary pressure does rise but there's a relationship between the rise in pressure and the increase in flow. So we take a thing called the total pulmonary resistance, which is your mean pulmonary artery pressure divided by the cardiac output. So if your flow went up, if your pressure went up to 30 millimeters of mercury and you were doing high intensity exercise and your cardiac output went up to 15 liters, the relationship, the ratio would be less than 3. So normally a ratio of less than 3 signifies a healthy circulation. And it may even be lower the more fitter you are and healthier you are. And clearly there's a spectrum of a blunted response in some people who are older, and these studies have been done in different age groups, including the healthy older individuals, to establish these values. So, you know, pulmonary hypertension and exercise is not necessarily a bad thing in terms of just if you take pressure, but you have to determine it in the context of flow and therefore pulmonary vascular resistance as well.
Lovely. I think that's really an interesting topic around pulmonary hypertension in the setting of exercise. And Dan, we're going to come back to you with a question related to that in terms of the new guidance that's coming out. Heba, if I can come to you, I'm just interested to know, we get these referrals for patients query pulmonary hypertension, you know, they're attending for an echo. Are there any clinical cues that we could be looking for as part of our assessment of patients, or anything that we can be using within their existing imaging that just might help us?
So help you to what? Escalate to?
Help us to escalate care for patients, or help us to be, I guess, more definitive with the diagnosis.
Yeah. So, I mean, from a clinical perspective, I mean, the worry would be if patients were accelerating in breathlessness, syncope is a concern. And then any evidence of clinically of overt right heart failure, so peripheral edema, or patient is struggling to lie down, orthopnea, really struggling with breathing. So these would kind of escalate in terms, support escalating maybe for more prompt reviews. However, when it comes to parameters that are picked up on transthoracic echocardiogram, I guess severity. So if we're seeing that extremely dilated right ventricle with septal flattening, and you see that the LV is compromised because of the severity in the RV dysfunction, these would all be clinical prompts for escalation for urgent clinical reviews. Yeah, so I'm not if that's.
Can the ECG help at all?
Yeah, of course. Yeah. So any signs of a tachyarrhythmia or a tachycardia, where if a patient, say, inappropriately heart rates of above 110, particularly in a tachyarrhythmia, would be a cause for concern, particularly in the context of somebody who has right-sided heart failure or RV dilatation. It's poorly tolerated rhythm in our patients with pulmonary hypertension. And then, of course, bradyarrhythmias also have a negative impact on patients with right-sided heart failure. So the extreme ends of those, and if a physiologist is comparing, say, to a previous imaging and noted that there is a new arrhythmia, then yes, that would be another prompt for escalation of urgency.
Perfect. I think that really helps us to be able to take the echo information, but if there are those additional pieces of information, we can escalate them to the cardiology consultant.
Blood pressure as well, I guess. So.
Yeah, of course. Dan, if I can come to you, it's just in relation to the European guidance. It looked very similar to what you and your author group had shared in 2018, perhaps with the addition of TAPSE on systolic pulmonary artery pressure. But it sounds as though, from what you were saying before, you're now thinking next level, which is TAPSE with strain. I just wondered if you had any comments on the guideline, or if there was anything of interest within that has kind of fed into the newer guidance.
Thanks, Kelly. That's a great question. So from an echo perspective, there were a couple of new additions from the ESC and ERS most recent update a couple of years ago. So the first, as you mentioned, is that estimation of RV to PA coupling. So that's the TAPSE by the PASP. And the second addition actually that they made was an assessment of the PA size in relation to the aorta. So is the PA bigger than the aortic root in the parasternal view? So that was the second slight addition, whereas before they were just saying the PA measurement. And both of those measures are valid. And I guess the key thing that we need to think about is how are those measures adding to the probability-based approach already? Because if you think about those measures, and what we found, and we've done research our own that Abdul's helped with, and we've got a really nice consortium within the UK, which is lucky, that collaborate and formulate this research partnership. And what we found actually is that it's not surprising that by the time you have an impaired RV to PA coupling, your PASP is really high. It has to be high for that value to be low. Actually, by that stage, you will have other markers of pulmonary hypertension. So the key question for us is, that's useful to have. It might be useful for prognostication, but is it useful for the echo diagnosis? That's the key thing here. Is this probability-based approach helping with the diagnosis? And we presented some work at the ESC Congress a couple of years ago, where we looked at the previous guidance and the addition of those two new markers. So the RV to PA coupling and the PA diameter compared to the aortic root. And what we found was that actually in those with a low thought to be low probability of pH, those markers didn't add to the diagnosis. So what was quite striking from that data, Kelly, is that in those, we had a population of around 300 patients, first-time attenders for pH assessment, all have had an echo and a right heart cath. And we separated them into low, intermediate, and high probability of pH on echo. And most of them, I think 96% with a high probability of pH on echo had pH at right heart cath. It was around 70% or so of the intermediate probability of echo had pH at right heart cath. But what was striking is in those that we felt had a low echo probability to pH, about 35% of those patients actually had pulmonary hypertension at right heart catheter. And not surprisingly, these other markers that adapt with more severe hemodynamic forms of pH, like your RV to PA coupling, like your pulmonary artery diameter, were completely normal in this group. So I think they are valid markers, but I'm not sure they're helping in the new pickup of patients with pH. And that's the key thing, because pH is such a multi-system disorder that unfortunately it takes 2 years. You know, it's astounding and very sad that it can take 2 years from symptoms to the diagnosis to be made, to be confirmed. And that's because it's a multi-system disease. You know, it affects the connective tissue, patients with rheumatoid issues and connective tissue disease, lung disease, heart disease. You can present in different ways. And so actually what we should be trying to do with the echo criteria is to improve the diagnosis, I think, in those with that low and intermediate probability. And I think that's where more novel markers like right ventricular free wall strain will help. I think what we've also learned is that if you look at other functional parameters of the right ventricle, it's probable that the radial function of the right ventricle falls earlier than the longitudinal function. And so actually I think in the proportion of these patients with pH, fractional area change is a really important measure to make. And also what we need to highlight in the next iteration, which we probably didn't as much as we should have, is the need to make our functional measures and our size measures of the right ventricle using the RV focused view. And I think that's really important.
Fantastic. I think that's really informative. I also suspect that if we were applying those additional parameters, we would probably be overdiagnosing some of these patients with pulmonary hypertension or referring patients inappropriately based on some of those additional parameters. Heba, if I can come to you, and you've somewhat answered this question already. I was going to ask you about RV strain and also 3D. But one of the things that you mentioned earlier was about serial change in the ACHD population. Do you still find those parameters useful?
Yes, absolutely. I mean, we have been increasingly using RV strain and now more recently 3D imaging. It's very useful in patients with congenital heart disease, particularly when the RV is geometrically more challenging, and even more so in patients with congenital heart disease when the arrangements are not conforming to normal standards. So although there isn't any there isn't any standard there isn't a standard protocolized guideline for using these parameters. However, it is really helpful for us in monitoring it via serial doing this particular imaging biomarker serially in these patients. It is supporting uh, supporting identifying when there is early signs of RV dysfunction, which may not be picked up through longitudinal measurements such as TAPSE or S prime or otherwise. Fractional area change, again, is there's a lot of inter-operator variability, and using 3D imaging is really encouraging and exciting, and it's a tool that I'm seeing being used increasingly, both congenital and non-congenital. So it's a very valuable tool, and I'm looking forward to seeing it implemented more in future guidelines, and so that we can use it more comprehensively in our practice.
Oh, I completely agree. I think we also need to make sure that we have equipment and the facilities to provide those additional measures. But it does seem to be in so many of our guidelines now, both strain and also 3D, which brings me on to another concept. So Abdul, I'm going to come to you for this one actually. So this relates to diastology. So as we learn more about pulmonary hypertension, there's this separation of the pulmonary hypertension due to left-sided heart disease from the other forms and classifications. In terms of the measurements, we can perform comprehensive diastolic function measurements. How does that help in relation to the treatment of this population of patients who have pulmonary hypertension from left-sided disease? How does it differ from the other types?
Okay, no, that's a great question. And I think it's a very important question because of the prevalence of pulmonary hypertension and left heart disease. Before I go into answer that, I just wanted to reiterate Dan and Heba's points that, pulmonary hypertension on echocardiography and a probability doesn't necessarily stipulate what type of pulmonary hypertension you have. I mean, we see three principal phenotypes, okay? One is overt precapillary pulmonary hypertension, where there's a right ventricular phenotype. The right ventricle is dilated, often with a high TR velocity. Even if it's incompletely captured at 3.5 or 3.2, we often get reports and scans where the recorded TR velocity is lower than what you'd expect for the degree of RV dysfunction, and that's because of an incomplete jet. And I think it's important to know, and I'm sure our echo community will appreciate this, that there's a disconnect between the severity of tricuspid regurgitation that you see in the degree of pulmonary hypertension and right ventricular dysfunction. And it's all to do with Doppler signals and what you can do to enhance that. And I think the BSc 2018 guidelines, which I should have elaborated more on when you initially mentioned to me, have got a very helpful practical approach and caveats and pitfalls about how to do measurements. When the TR velocity is high, you're more likely to have right ventricular dysfunction. But occasionally we see some patients with high TR velocity with preserved or good right ventricular function. And therefore, it's always important in the context of when the scan is performed. So if it's in the context of a lung decompensation, etc. With regards to probabilities, I want to just also follow on from Dan's point. The probability of pH depends on these parameters, and sometimes if your TR velocity is more than 2.9 meters per second, you are very likely to have a mean pulmonary artery pressure of more than 20 millimeters of mercury. There's some nice data from Robert Nae and Michael de Alto published in 2022 to validate the ESC ERS 2022 guidelines to say, well, if we use the new cutoffs, can we still use the same TR velocity? And they nicely demonstrate that that is the case. So they independently show that TR velocity of more than 2.9 would equate to, they didn't add for RA pressure because the problem is RA pressure, it can be quite variable. So they just took TR velocity. And one of the things is, which I find as a referral center, we receive lots of referrals, and the context of the echocardiogram is done in a scan is requested in a patient population who's at risk for pulmonary hypertension, okay, or they are done in undifferentiated patients with breathlessness, murmur, or for other reasons, or suspected heart failure, and pulmonary hypertension may be a principal or an additional finding as well as other pathology. And so the low probability patients, you have to be absolutely certain. If it's a patient that's quite symptomatic, I'm not sure obviously what the requester puts, but if they put a patient with scleroderma with exertional breathlessness and has a low TR velocity with good RV function, we need to be absolutely clear in the report. And this is something that the current guidelines highlight, but I would emphasize it again for any future iteration, that they must qualify that the TR jet was incompletely captured or underestimated. Likewise, we don't want people to be lulled into a false sense of reassurance when they see a reported pressure, because most people who, unless you're doing echocardiography or reviewing the images, you will look at the conclusions in the report. They won't necessarily go through all of the detailed metrics. So I think it's very clear that in the conclusions you put RV dilated and impaired, whether it's volume loaded or pressure loaded, and so that line is next to the PA pressure, so people can interpret accordingly and action accordingly. Because what you don't want to happen is people in whom they think there's a low probability of PH, but actually do have PH, but it's a technical issue with the scan not being referred. And the low probability patients will fundamentally, as far as I'm concerned, I'll be interested to hear Dan's thought, are those patients who have got early disease in an at-risk group. They may have connective tissue disorder. They may have chronic PE with very mild resting hemodynamics. Remember, these scans are done at rest, and I know we're going to talk about exercise. Or there may be elderly patients with mild pulmonary hypertension, very likely to have left heart disease. So coming back to your question about diastology and left heart hemodynamics, I think it's really important because the prevalence of pulmonary hypertension associated with left heart disease is by far the commonest. It accounts for at least 50% of patients with PH, as well as those with lung disease. So that your pretest probability on paper before you even get a referral is 75% chance they're going to be left heart disease or lung disease. Now, we see lots of referrals from cardiology departments where they say there's nothing wrong with the left heart. And that's because they've taken a very precursory look at the report. And we see, and so I think an emphasis on trying to qualify the probability of underlying left heart disease was very valuable in a report. Now, we don't stipulate that, but I think we should be thinking about that to guide people looking after these patients, because the treatment of left heart disease, and that's a heterogeneous group. We've got heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. We've got patients with concomitant or isolated significant valvular heart disease. So, and the treatment options are variable for these patients. Now, heart failure with reduced EF has a very clear, defined treatment pathway with, excellent evidence base. HFpEF has got some emerging data to manage these patients. And fundamentally, these patients will have a dilated left atrium, various degrees of structural abnormalities in the left ventricle, such as LVH. They may have varying degrees of mitral regurgitation, often with AF. And so the guidelines talk about, and so the BSc have published excellent guidelines in 2024 about left ventricular diastology and our new way of assessing that, and including LA volume, E over E prime. I think there's no single test that gives you the complete answer. You have to integrate parameters, and the clinician or the end user needs to integrate a report in the context of their patient. So, but I think the BSc guidelines on diastology are really helpful. If you've got an elevated E over E prime, provided there's no mitral annular calcification, you've got a dilated left atrium, and if you've got the ability to do left atrial strain, that almost makes a full house that there's significant left atrial dysfunction and there's left atrial hypertension. Now, that doesn't mean that they will likely have pulmonary hypertension, but you have different phenotypes. So I said the predominant right ventricular phenotype, we've got the left heart phenotype where there may be mild pulmonary hypertension, and that's understandable. The treatment for these is their optimization of their left heart failure management, hypertension control, diuretics, use of spironolactone, and use of SGLT2 inhibitors in appropriate patients. The valvular heart disease clearly needs timely diagnosis and timely intervention to prevent the development of severe pulmonary hypertension. And thankfully, this is still, it's not as common as it was in the old days when we used to see people with severe rheumatic mitral stenosis, but we still see significant pulmonary hypertension in patients with severe MR. Now, and then for the HFpEF-PH, now we do not use the evidence base for the use of pulmonary vasodilators in the presence of pulmonary hypertension in people with left heart disease is either neutral or negative. There's only one study that says that if you've got combined severe pulmonary hypertension that you may derive benefit. We don't, the guidelines give it a class 3 recommendation. Now, many of our patients who've got pulmonary arterial hypertension will have comorbidities, such as diabetes, hypertension, AF, COPD, and those patients will require right heart catheter to hemodynamically partition where the problem lies, whether they've got pre-capillary pH, post-capillary pH, or a combination, and then we do an individualized treatment for those patients. So I hope that it was a long answer, but I hope it answers your question, but gives you some more meat on the bone with regards to the spectrum.
Oh, 100%. I think that that's really useful, and you've raised some really valid points in relation to considering pulmonary hypertension in left heart disease. Heba or Dan, did you want to add any comments into that response?
Yeah, I was going to say actually, congenital heart disease patients, the commonest pulmonary hypertension in these patients is not the precapillary, but emergingly the left heart disease. And so diastology in the left heart, in the congenital heart disease population is also really important, sometimes overlooked. And so sometimes, people presume that congenital heart disease patients are at risk of precapillary pH, and that's the majority, but no, not at all. It's actually left heart disease, which is emerging. And so taking into consideration everything Hameed said is really important. As for the pre and post capillary pulmonary hypertension, yes, I mean, I have an interest in that aspect as well. And there are some emerging therapies in left heart disease like vericiguat, which seem to overlap with some of the therapies that we give in pre-capillary pH. So it'd be really interesting to see in the future that patients who do have combined pre and post capillary pulmonary hypertension, what emerging therapies there may be available to them. And certainly the therapies like SGLT2 inhibitors are really helping in that area of management. I think it's an emerging world, left heart disease and pulmonary hypertension. So yeah.
Thank you, Heba. Dan, I'm going to come to you. Do you want to make any comments before the final few questions?
A couple of comments, I guess. That answer by Abdul and then Heba's response were fantastic, weren't they? So, and we'll come on to what potentially is going to come into the next pH guidance. The one thing which I think is really important that Abdul said is that with the echo, we should be trying to guide the referrer at essentially is it pH due to left heart disease or pH due to pre-capillary pH, and actually you'll be surprised that the E by E prime doesn't have to be that elevated for it to be pH due to left heart disease. So there is a grey zone between maybe 9 and 14 where you think it's not rip-roaringly elevated. It's not above 14. It's not the textbook definition, but it's enough to cause post-capillary pH in terms of the echo marker for it. And then the only other comment was what Heba was talking about before with 3D imaging. And that's really important with the ventricle because all of our functional parameters measure essentially two-dimensional measures in a really complex three-dimensional chamber. And the great thing about the 3D volumes is that it looks at the outflow tract, which is neglected. So the outflow tract is a really important part of congenital heart disease and non-congenital heart disease, and it can contribute, 15 to 20% of stroke volume and ejection fractions, and that's why 3D RV is really important, and it will become more of a player in future iterations of international guidance, I think.
Perfect. Okay. So I think one thing that people are probably very interested in is we've all heard the rumors about the new guidance that might be released by BSE. So I think that's currently under construction. Dan, can you tell us a bit about what that might look like, or some points that are currently still under debate, maybe with a response to whether or not pulmonary hypertension in the setting of exercise is advised?
Yeah. So I guess if I touch on that last question first in terms of exercise pulmonary hypertension. So I personally don't use it much outside of the setting of whether there's asymptomatic left heart disease that we want to prove is severe, essentially. And so there is more data coming out in terms of exercise echo for pulmonary hypertension. The parameters I use, so we have an ergo, so a semi-supine bike. We would use a ramp protocol, increasing the resistance by 25 watts every minute to 2 minutes. We're aiming for 10 minutes of exercise. And for the right heart perspective, we're looking for a TRV of 3.4 or a TR max of 50 millimeter mercury. There is data, as Abdul correctly stated, to suggest that actually looking at the mean pulmonary artery pressure over the cardiac output, so your pressure over flow, is probably better. And there are, as you all know, non-invasive ways to do that, but they become tricky, particularly when you're looking at exercise and you're trying to do, the continuity equation to get your LVOT and then do your aortic valve Dopplers, your LVOT Dopplers, and you're doing your pulmonary artery systolic pressure. So there might be more stuff coming through on that, but my take home for exercise is that it's mainly to establish left-sided valve disease, and sometimes in diastolic dysfunction, or to show up diastolic dysfunction in someone with otherwise normal parameters. In terms of the pulmonary hypertension guidance, it is under construction. We're hoping for it to be published in the last quarter of this year. As with all of our BSc guidance publications, it's going to be quite hands-on in terms of a how-to type structure, in terms of how to make the measures, the advantages and the limitations of all of the measures. We will be sticking with a probability-based approach. I think that's internationally accepted now in terms of limitations that we've talked about with pulmonary artery systolic pressure as a precise measure. We'll probably be looking at more novel techniques to see how that can help with the probability-based approach, like right ventricular free wall strain. We've mentioned other functional markers like fractional area change. I think it's important that we look at the final probability and help the referrer to have a feel for whether it's left heart disease or precapillary pH. And so there'll be guidance around markers to look for that would indicate potentially left heart disease, and Abdul's mentioned the excellent diastolic guidance by Sean Robinson. So things like your atrial strain, your E by E prime, and the other things that we'll be looking at. I think it's really important to have a congenital section. We didn't have that before. Congenital disease is increasing in all of our hospitals, irrelevant of where you work, and it's only going to increase. And all of the points that Heba made are really well made, and so we need to help our echocardiographers in terms of those congenital patients, because these probability-based approach do not stand true for the congenital population. And there will be a bit on exercise echo because there's data coming out on that. I don't think you can take AI out of any equation. There might be a paragraph on AI and some of the things that are currently being looked at, but in a nutshell, it's going to be similar in terms of the foundation of the previous guideline, but we're going to add to it more novel markers and the feedback that we've got back in terms of what do we do with this approach and how can we distinguish right from left heart disease.
Perfect. That sounds wonderful. I think that'll be a very much appreciated update on the guidance. I just wanted to say a really big thank you, Heba, Abdul, Dan. Thanks so much. It's a pleasure to have pulmonary hypertension experts, imaging experts, echo experts here delivering this message to our membership. And on their behalf, I just wanted to say a really big thank you.